شكرا جزيلا. صباح الخير عليكم جميعا. Thank you very much for the organizing committee and Professor Sanaa Yousef for the kind invitation. It's always a great pleasure to be here in Cairo after the pandemic, almost 2 years. It's always good to see familiar faces. Inshallah, I wish this Congress all the success. Over the next 20 to 25 minutes, I would like to share with you some clinical tips in the management of common GI disease that you will encounter in your practice. These are the learning objectives of my talk: to use and correctly interpret lab tests to diagnose common GI conditions, demonstrate a cost-effective approach to investigate common GI conditions, recognize when it is appropriate to refer a patient to a subspecialist. So I will start with the case, so just to incorporate this into your practice. So this is a 10-year-old girl presented with abdominal pain, diarrhea for the past 2 to 3 months. Pain is postprandial, lower abdominal, occurs 4 to 5 times per week. Stools are loose, explosive, no blood or mucus. Defecation provides pain relief. This is a very important tip when you take the history. Also, no loss of appetite, no loss of weight, no family history of note. Examination is completely benign. This is a very common scenario you see in practice as a general practitioner or as a pediatrician. So somebody asked for a celiac test and they did a celiac panel. TTG IgA was less than 20, negative. Serum IgA was normal. TTG IgG was positive. Anti-endomycin antibody was negative. Anti-DGB, which is the deaminated gliadin peptide, IgA, was negative. And the IgG was positive. This is very common scenario. We see it in our practice as gastroenterologists. A lot of patients come with non-specific symptoms with abdominal pain and positive serology. Where to go next or what to do with these patients? So I would just like to take your opinion here in the auditorium and what will be your response. So you will diagnose celiac disease, start a gluten-free diet. You diagnose irritable bowel syndrome and treat accordingly. You test for celiac genes or you refer for GI for endoscopy. Number 2. Okay, so we have 1 going for number 2. What about number 1? Anyone will go for number 1? 3, 4. Okay, so you are right. You diagnose irritable bowel syndrome. This is very classical presentation with irritable bowel syndrome. Pain that's not significant. It goes away with defecation. So this is a classical for irritable bowel syndrome. But these are potential questions I would like to highlight and share with you. That is, the panel of tests for celiac disease is better than a single test. Should we do the whole panel or just choose 1 test? And if we choose 1 test, which test to go with? And what is the significance of abnormal IgG-based celiac test in this case? And when should the celiac genes test be done? What are the scenarios in which celiac serology should be tested? And is it okay just to try a gluten-free diet without having a diagnosis? So first of all, I would like to give you a background of serology that we use for celiac disease, starting from 80s and 70s with anti-gliadin antibody, whether it is IgG or IgA based. This is obsolete now. We don't recommend to use anti-gliadin antibody. We're using the new fashion or the new generation of anti-gliadin antibody, which is the deaminated gliadin peptide, IgG and IgA, with very high sensitivity and specificity. Anti-endomycin antibody is very good test, but the problem with it is very expensive and it is operator dependent because it's indirect immunofluorescent test. You look at colors, it is operator dependent, but the positive predictive value is very high. Almost always, if you have anti-endomycin positive, almost always this child have celiac disease. Tissue transglutaminase antibody is the most sensitive screening marker for celiac disease, especially the IgA. So if you want to put everything into 1 table and look at sensitivity and specificity of different tests, you start with anti-gliadin antibody. It is in the 80s range. The TTG IgA, this is the best test we can use to screen for celiac disease, going from 95% sensitivity and 96 up to 98% of specificity. EMA or anti-endomycin antibody has very good positive predictive value, 98% of specificity. Anti-gliadin antibody are not bad as well, especially the IgA. And these are recommended in small age children below the age of 2. So one message from this case that choose TTG IgA and serum IgA level alone. Most cost-effective and reliable initial test for celiac disease. Why we do serum IgA total? Because you want to avoid false negative test. If you have IgA deficiency, which is more common with autoimmune disease and celiac disease, you need to do IgG-based test or go ahead and do endoscopy to confirm or rule out your diagnosis. So special consideration with IgA deficiency, like I mentioned, you either go with IgG-based test or go for biopsy if there is a clinical indication. Second question, what is significance of isolated IgG-based test? So like in this patient, she have TTG IgG positive and she have deaminated gliadin peptide IgG positive. Are they significant in the light of having normal serum IgA and normal TTG IgA? And the simple answer, based on many studies from JBGN and other society, that isolated rise in the IgG-based test, whether it is TTG or anti-deaminated gliadin antibody, is not significant. Your serum IgA total and TTG IgA is the gold standard to screen for celiac disease. So if you get isolated elevation of IgG-based test, unless you have a strong clinical indication, you just ignore it because it can be normal in general population as well. Regarding the genes, we have to understand that there is a genetic and environmental component for celiac disease. Celiac disease is considered the most common autoimmune disease worldwide with a prevalence of 1%. This is a biopsy-proven diagnosis. If you go with serology proven diagnosis, this will rise to 2 to 3%. In family members, first-degree relatives, this is what we do in our practice. When we have a child or index case, we always screen family, whether they have symptoms or no symptoms. So we screen father, mother, first-degree relatives, first-degree relative, because the lifetime risk is about 10%, which is quite significant. In addition to the high-risk group like Turner, Down, Williams syndrome, and selective IgA deficiency. So you have to understand that you have to have HLA genetic makeup or genetic susceptibility in order to have the disease. 98 to 99% of patients have HLA DQ2 or DQ8 in order to have the disease. If they don't have this genetic makeup, most likely the diagnosis is not correct and you have to work for other diagnosis. So you can have HLA DQ2 and DQ8 but not having celiac disease. If you don't have the HLA makeup, most likely you don't have the diagnosis. So this test, when you do HLA genetic study, this is a test to rule out celiac disease and not to rule in celiac disease, because this HLA is shared by 30 to 50% of general population as well. So we use it to exclude celiac disease, but not to diagnose it. So you have to put everything together. It's like a puzzle. You take your history, your physical examination, your serology test, which are excellent markers, in addition to your biopsy in order to make the diagnosis. What about gluten-free diet? Gluten-free diet is a big deal. Putting a child and family on a gluten-free diet, it's a lot of work, a lot of effort, a lot of compliance, and this is not for a day or 2 or 3. This is for life. So you have to think twice before making the diagnosis and prescribe a gluten-free diet for your patient, because this will require input from a certified dietitian. It requires a regular follow-up. This is not the story of just diagnosing celiac disease and send him home or see him every 3 to 4 months. No, you have to monitor these children for compliance. You have to monitor their nutritional status, their symptoms. The easy part of celiac disease is just to make the diagnosis. It is simple. But the hard part is to check their compliance, and we do this by getting a dietary history, by getting a GI history, general history, and we repeat serology as well to make sure they are returning back to normal. We don't repeat endoscopy and biopsy because it is too invasive and it doesn't reflect what's going on, because it will take at least 2 years for the villi to regenerate, even with a child who's compliant on a gluten-free diet. So what's the problem of the gluten-free diet? It needs constant vigilance, many hidden sources, not only food. So many drugs, makeup, toothpaste, many, applications like envelope glue. So many things can have gluten, and you have to be really vigilant when you counter these patients and when you follow these patients in the clinic. And also it limits social interaction for the family in going out, eating at restaurants, traveling abroad. This is a lot of hassle for the family. Adding to this, the cost of a gluten-free diet is huge. Although we are supporting this through the government, still, if you go to any big supermarket and look at the gluten-free products, compare it with the normal product, there is a huge variation in prices. So what is the fact with the gluten-free diet? It contains more sugar and fat, so it can lead to obesity. It's higher in sodium, higher in cost, and it's less nutritious. So you have to monitor these patients for nutritional deficiency, especially fat-soluble vitamins A, D, E, and K, in addition to B12, thiamine, riboflavin, zinc, and iron. Because iron gets absorbed in the small bowel, especially in the second part of the duodenum. So if this child is not compliant with the gluten-free diet, the iron will not get absorbed very well. So these children can come with refractory iron deficiency anemia despite treatment. This is very common indication for celiac disease. You get persistent iron deficiency anemia despite good duration of treatment and good compliance. So this study look at the quality of life with teenagers. What are the two questions that comes from this study? What do you like least about the gluten-free diet? They answer that they cannot enjoy eating with friends and they have to check everything before eating. And this is a hassle for children. They have to get used to it. They have to read the labels. And even with labels, in some countries, still the manufacturer information is not very clear. It doesn't say gluten or wheat clearly. You have to be vigilant. You have to have a lot of knowledge, and nobody can master this in one day or two. They need to follow with a registered dietitian. They follow their pediatrician and gastroenterologist in order to master the skills of a gluten-free diet. So the bottom line, that putting children on a strict gluten-free diet of life is a big deal. You have to think twice. You have to make sure about the diagnosis and before labeling them as a gluten-free diet. Keep in mind that a gluten-free diet is not only prescribed for celiac disease. There are other indications like gluten ataxia, peripheral neuropathy. You have non-celiac gluten sensitivity, which is a subtype of irritable bowel syndrome, or you have wheat allergy, which is IgE mediated disease. This is shifting the gears and talking about another case. This is 14-year-old girl present with effortless vomiting for the past few months after every meal, recently ingested food or fluid without blood or bile, occurs several times, usually for 1 hour after eating. So spits out the contents and reswallow. This is mixed with saliva as well. Occasional burning in her throat, never bothers her at night. This is very important statement to keep in mind. Examination is completely normal. So if you are the pediatrician seeing this girl in the clinic, what will be your response? You diagnose gastroesophageal reflux disease and start proton pump inhibitor. You request tests like upper GI study, impedance, pH test, refer to GI or refer to behavioral health or others. What will be your answer? Okay, so this is the case. 14-year-old girl present with effortless vomiting for the past few months. This is usually the food. No change in the texture or the smell of the food. Recently ingested food comes out. No other symptoms, did not happen at night. Examination is normal. GERD? واحد. تمام. Number 4. Okay, so we have different answers here. GERD is the common thing. Yes, 4. Because this is rumination syndrome. Rumination syndrome can happen in infants and can happen in older children and adolescents. And this is, the classical presentation of rumination syndrome. This is repeated regurgitation, rechewing, reswallowing of expulsion of food that begins soon after ingestion of food and does not occur when asleep because there is involuntary contraction of abdominal muscles and there is regurgitation of the contents. It's effortless regurgitation of contents into the mouth. It's a habit. They get used to it, and it needs a lot of diaphragmatic breathing and relaxation technique in order to, relieve this problem. It will take time to be relieved. It's like tics or other functional diseases, but the key point is not to label them as gastroesophageal reflux because your proton pump inhibitor prokinetics will not work and you will just get side effects from prescribing them. It's not preceded by retching. This is very important and does not happen at sleep. So the other differential diagnosis, like some of you mentioned, like GERD, usually they present in older children with burning sensation with retrosternal chest pain, some night symptoms, some aggravating factors like certain type of food, like carbonated drinks, chocolate, caffeine, and others. With gastroparesis, you look for old food, usually 24 hours, 16 hours after ingestion, they still have, the same food. With achalasia, it's worse when laying down. Achalasia is the failure of relaxation of lower esophageal sphincter and increase in resting pressure of lower esophageal sphincter, and they can present with motility issues in the esophagus. With bulimia, especially in this age, and anorexia, you have to be careful and you have to rule out eating disorder definitely. For confirmation of rumination syndrome, it's a clinical diagnosis first, and then you have to do high resolution esophageal manometry looking for delta sign, delta wave in the manometry. This is another child, another classical scenario comes to the emergency department or to the pediatrician, 6-year-old male, vomiting episodes, usually 3 of such episodes in the past 2 months, sudden onset of forceful vomiting, it's like a switch, starts, stops. Vomiting is non-bloody, non-bilious, vomiting several times over 5 to 6 hours. This is very intense nausea and vomiting. Some generalized abdominal pain with vomiting, no diarrhea, no fever, hospitalized on 2 occasions for IV fluid. He get dehydrated, comes with metabolic acidosis, get IV fluid. And symptom-free between the attacks. I think this is a familiar scenario to a lot of us here in the room. So your response to diagnose viral infection, reassure, diagnose gastroesophageal reflux, start PPI, request test, refer to GI, or do something else. What will be your response? 2, diagnose reflux again? Okay, but reflux doesn't happen once or twice a month. Usually it's a constant and the chronic symptoms. You don't get free symptoms in between. This is a diagnosis of exclusion of cyclic vomiting syndrome. Okay, I see a lot of missed cases of cyclic vomiting syndrome. Unfortunately, they come and labeled in the emergency department as gastroenteritis, although they don't have diarrhea, they just have vomiting. They come, take IV fluid, they go home. And then after 1 month, the same scenario. And you are missing that this child have a pattern, which is a stereotypical, happen every month, usually 2 to 3 days. Very classical presentation, very stereotypical, and you have just to exclude others and make the diagnosis of cyclic vomiting syndrome and provide abortive and prophylactic treatment if needed. So the criteria, as per Rome criteria for cyclic vomiting syndrome, you need 2 or more attacks of intense nausea and paroxysmal vomiting lasting hours to days in a 6-month period. Episodes usually stereotypical, they look alike. Episodes separated by weeks to months of a free health in between. This is very important. You get symptom-free interval in between. And after appropriate evaluation, symptoms cannot be attributed to another condition, cannot be explained by a medical condition. This condition is quite variable. I have seen children with mild, it happens only once a year or once every 6 months, and I have children go to the intensive care unit because of this, and requires, IV steroids and others. So it's very variable way of presentation. And to put this into one slide and perspective, it's just all along the same dimension. Looking at the spectrum of disorder, if it is more in the head, it is migraine headache. Migraine headache, they might have nausea, vomiting, abdominal pain, and also abdominal migraine. Abdominal migraine, they might have nausea and vomiting. But look at the predominant or distressing symptom. If it is too much pain, this is abdominal migraine, and you need EEG to diagnose it and your clinical diagnosis as well. If it is more vomiting, this is more going with cyclic vomiting syndrome. And most of these children tend to have family history of migraine headache, especially in the mother. So these are some key features about cyclic vomiting syndrome, usually happen between the age of 5 and 7. This is very common and everywhere worldwide. There are reports about cyclic vomiting syndrome, about 1 to 2 cases per week, with family history positive in 60% of cases. Associated feature, usually anxiety, mood disorder, autonomic dysfunction. If you see 1 or 2 cases like this, they are very classical. These children look pale, tachycardic, they have sweating, they don't like any sound, they don't like any light. So it's like a picture of meningitis, except they don't have neck rigidity or meningeal irritation signs. They really miserable when they have these attacks. And the natural history, usually we tell the parents that this will take time and it might transform into migraine headache into adolescent or adulthood. And it might go away. And also there is no test to confirm. This is no biomarker to diagnose it, like celiac disease or other condition like inflammatory bowel disease. You need to exclude other common causes of nausea and vomiting. These are key features. I mentioned stereotypical onset usually at night because it's related to cortisol release and circadian rhythm. Also usually abrupt onset of starting and ending. It's like a switch on, off, and usually it lasts 4 to 6 hours and sometimes more. And very important differential diagnosis to rule out when abdominal pain is a prominent feature, you have to rule out surgical abdomen. If you are not happy about abdominal examination, think about obstruction, malrotation. This is very important. You obtain X-ray, abdomen, 2 views, and to obtain upper GI serious when the child having attack as well, because you want to rule out surgical abdomen and uretropelvic junction obstruction and pancreatitis. Of course, if the child have intense epigastric pain radiating to the back, you have to obtain amylase lipase to rule out pancreatitis in addition to your ultrasound. Also, metabolic condition, a lot of mitochondrial disease can be triggered by fasting or illness associated with marked acidosis and hypoglycemia and increase in lactate as well. Also, intracranial causes, you have to keep this in mind, and you have to do fundus examination, do imaging of the head, and rule out, intracranial causes of vomiting. We diagnose many conditions in the GI clinic with brain tumors, and they come to us in the clinic with GI, with vomiting. So please keep your mind very broad and think about non-GI causes of vomiting, like urinary tract infection, pneumonia, metabolic causes, intracranial. Always think about other systems when you encounter a patient with vomiting before labeling them as having a GI source of vomiting. So upper GI serious in all cases and select workup in all other cases. In our practice, because we are the last one to see this patient, I do the whole workup. I even do celiac screening for these children. We do abdominal ultrasound, we do lipase, amylase, electrolytes, acid-base, blood gas, lactate, ammonia, head CT or MRI to exclude intracranial causes. And all of this is negative, and sometimes even we do endoscopy for these children in order to rule out all possible abdominal causes before labeling these children as cyclic vomiting syndrome and start treatment. For acute phase, we give antiemetic like ondansetron. You give IV fluid with maintenance or 1.5 maintenance dose. Good sedation, you can give a small dose of clonazepam to calm them down. If the attacks are too frequent, so 1 or more attack per month, you can give ciproheptadine for children below the age of 5, or amitriptyline, which is tricyclic antidepressant with a small dose, and then increase it in children above the age of 6. Abortive treatment, you can give simatriptan and rizatriptan as well in order to ease the nausea and vomiting. There are many case reports in cases of severe cyclic vomiting syndrome to give IV dexamethasone. I think we cover all these points regarding the red flags or important points to label child as cyclic vomiting syndrome. So this is a small table I just put for you to differentiate different causes of vomiting, starting from common things like gastroesophageal reflux disease. Usually they can present with effortless postprandial vomiting. You diagnose by history. You don't need to do a pH or endoscopy unless you have a doubt about the diagnosis or the child failing medical treatment and you want to schedule a surgical treatment for reflux. And treatment usually lifestyle modification and acid suppression with a proton pump inhibitor. Eosinophilic esophagitis is another diagnosis that we see more and more nowadays, and it's very important differential diagnosis for a child with vomiting, especially if the child have family history of atopy or personal history of asthma, eczema, or other problem. Child present with dysphagia and food bolus impaction, especially in older children. Younger children who have failure to thrive, persistent vomiting, not responding to your classical gastroesophageal reflux treatment, keep eosinophilic esophagitis in mind. Keep in mind that eosinophilic esophagitis requires endoscopy and biopsy to make the diagnosis, and we need to take biopsy from different levels of the esophagus with the classical magic number of 15 bare high power field of eosinophils in order to label these children as eosinophilic esophagitis. Cyclic vomiting syndrome, as I mentioned, episodic, typical attacks, symptom-free interval in between, usually by history and excluding other diagnosis. Rumination syndrome with effortless meal-related regurgitation, behavioral modification is the key. Gastroparesis, usually in children with cerebral palsy or neurological. Usually they can present with all content food that kind of stays in the stomach and come through the mouth up to 24 hours or sometimes more after ingestion. And you need gastric emptying study to support your diagnosis. This is my last case. This is a common scenario. I'm sure that everyone sees this. 10-year-old boy, previously well, presented with abdominal pain 4 to 5 times per week for the past 4 months, present with very umbilical pain, poorly localized, usually after meals, last 30 minutes, never wake him at night, no nausea, vomiting, diarrhea, constipation, loss of appetite or loss of weight. Mother state that he's anxious and he get a problem at school. Examination, he looks well, he's not in distress, abdomen is soft and lax, mild epigastric discomfort, all other systems were normal. So what's your response for this case? You diagnose functional abdominal pain, you manage accordingly, you request test, you refer to GI, refer to behavioral health, or do something else. Number 1, so functional abdominal pain. Excellent. Your partner sent lab, so he works with you in the clinic, H. pylori came positive. This is very common scenario. What you will do, you just ignore the test, you treat with PPI and antibiotics, you shoot your partner, you order more tests. Okay, that's a good response. Oh, you refer to the GI? Okay. But as a general pediatrician, your nearest GI is 1,000 kilometers away from you. You are the pediatrician, you have to make a decision. Number 2? Okay, that's an acceptable answer. What others? Urea breath test. Yeah, we'll have a talk about it. So this is the problem with H. pylori. These are the potential questions. Does H. pylori alone cause abdominal pain? In the absence of peptic ulcer disease, should you treat H. pylori? And when and how should you treat for H. pylori? And should you test for eradication after treatment? And if so, how? These are very valid questions. So the common, factoids or facts about H. pylori that almost 50% of the world population have H. pylori. I'm sure here in this area, we have much more prevalence of H. pylori. In my practice, I do H. pylori for everyone. Every endoscopy, you are doing H. pylori. And to tell you the truth, children in our area and country are infected and colonized with H. pylori very early. If you read the literature, they start to colonize by the age of 5, 6. Our children, less than 1 year, they start to be colonized with H. pylori. And, almost always any child who is above 5 or 6, they're almost always positive and they have nodularity in the stomach, and H. pylori come positive with the claw test that we do as a rapid test bedside during the endoscopy and histopathology later. But the H. pylori can cause many diseases like peptic ulcer disease, duodenal, gastric ulcer, or esophageal ulcer. Most children with H. pylori, they don't have peptic ulcer disease. And this is the key message I want to transfer here. And the treatment of H. pylori in children with functional abdominal pain without peptic ulcer disease does not improve pain. And this has been shown in many studies worldwide, not only in North America or Europe, but always also from the Far East, Middle East. So you need to have endoscopic documentation of peptic ulcer disease. I don't like any diagnosis based on upper GI test or ultrasound or whatever. You need to see the mucosa yourself and take biopsy and visualize these children who comes with peptic ulcer disease, because it's a big deal. You need to monitor these children, you need to give treatment, and you need to repeat endoscopy in 3 to 6 months to see the response to treatment. Usually, peptic ulcer disease is not very common in children. We don't see probably 1 or 2 cases in our practice every year or so. And when they come with significant symptoms. They come with significant pain, hematemesis, melena or other symptoms. Very rarely I have children with significant peptic ulcer disease in our practice. Most of children, they have non-erosive esophagitis or mild, pangastritis. And the treatment of H. pylori in children also depends on the local resistance knowledge. You have to know your resistant pattern in the area before prescribing the treatment. There are many ways to treat H. pylori. You either give triple therapy for 10 to 14 days with amoxicillin, clarithromycin, plus PPI. I use sequential therapy when we combine 2 antibiotics, amoxicillin, clarithromycin. Then we add Flagyl for the next 7 days. And it seems to work very well, especially in the areas with high resistance. PPI should be completed for 2 weeks. And also the acid suppression alone, if you give proton pump inhibitor alone, it can control symptoms and heal ulcer for peptic ulcer disease. But you need to eradicate H. pylori in the light of peptic ulcer disease. You cannot leave it without treatment. And this is a very good indication to give H. pylori treatment. Also, failure to eradicate H. pylori result in more than 80% recurrence of ulcer within 1 year. This is why you have to monitor these patients and repeat endoscopy in 3 to 6 months. And keep in mind that symptom resolution does not mean you eradicate H. pylori. You get a lot of eradication only with the placebo or giving proton pump inhibitor. Make sure that you do urea breath test, as doctor mentioned, or you do a fecal antigen test at least 4 weeks after completion of treatment. And the child should not be on acid suppression in order to avoid any alteration in the result. Thank you very much for the questions.
Assalamu alaikum. Good morning. It's my pleasure to be among all of you today, and after a long time being physically with all of you after this pandemic. I'd like to thank Professor Dr. Sanaa Yousef for the kind invitation في المؤتمر الأم للنيوتريشن يعني over الميدل ايست والوطن العربي، وبشكركم جميعا طبعا على حضوركم. ودكتور محسن نقول له كل سنه وهو طيب. انا كنت عايز اقول لك انا شايفها الصبح، قلت هقول لك كل سنه وانت طيب. الحقيقه النهارده هنتكلم على حاجه نسميها يعني بريد اند باتر للبيدياتريشن ان هم بيشوفوها في الاوت بيشنت كلينيك بتاعتهم، او حتى ممكن نشوفها في المستشفى. نتكلم على الكونستيبيشن، محتاجين نعرف الساينتفك باك جراوند، براكتيكال تيبس في الايفالويشن وفي المانجمنت او في التريتمنت. اور ايم توداي النهارده انه to change our baby's direction from German to French way. يعني ايه نغيرهم من German to French way؟ ده اللي هنشوفه في الاخر في اخر المحاضره. Just a declaration in the Corona era. How many were infected with Corona? Okay, تمام. How many vaccinated? ما شاء الله. It's a wave. We are in a safe hands. ومين جمع الحسنيين انه infected و vaccinated؟ طيب الحقيقه يعني ممكن في النص نبقى نسال شوفي if I'm coming closer to you don't run and was vaccinated. وحتى يعني على الماشي كمان and just to give me a kiss or hug طبعا depend على الجندر. Just we'll start with what's the most dangerous alphabet that we know. تفتكروا ايه اخطر حرف في الالفابت في